Let me call on Supriya Joshi to maybe bring this home even more, to give us a case that can help us sort of chew on some of the facts and apply to something that's real life. Supriya, please take over and lead us through this case.
Thank you very much for that intro. Can you hear me?
Loud and clear.
Perfect. Okay, so thank you, James, for that great summary. To all the other speakers this morning, it's the perfect lead-in to talking about this case that I'm going to move right along into today. So we have this lovely patient whose name is Joy, and she was referred to hepatology for a fatty appearing coarse liver as per her abdominal ultrasound. And this ultrasound was done in hospital for abnormal liver enzymes during a recent admission. It states the patient is concerned, please assess. Then it states, FYI, she was just discharged from hospital with atypical chest pain and diagnosed with an NSTEMI, and was also told she is now diabetic. In hospital, they did try to start her on a statin, but she did not tolerate it. She stopped taking it, and it was also mentioned that she is sedentary, and recently she's more sedentary due to recurrent gouty arthritis of her great toe. And the doctor also said this was a wake-up call for her. She wants to fix all of this. What do you suggest? So she's coming into the office, and on her intake form, her past medical history, in addition to what was just disclosed, is that she does have high blood pressure. She is hypothyroid, has a history of gout, and now has a new diagnosis of cardiovascular disease. Surgically, she's only ever had an appendectomy, and it was remote. It was more than at age 20. And as per the hospital discharge summary, she is now on typical post-MI medications, except her statin. She's on metoprolol, she's on aspirin, she's on Altase, she's on Synthroid, which she was on beforehand. She's also put on metformin, 1 gram BID, and empagliflozin, 25 milligrams daily, to manage her new diagnosis of type 2 diabetes. Her PRN medications include Advil, colchicine, and vitamin D when she remembers. So with this referral, the included tests include an ultrasound showing that a heterogeneous coarse appearing liver with areas of focal fatty sparing, hepatomegaly, fatty pancreas, everything else is normal. Her echo shows an ejection fraction of 45% with some wall motion abnormalities in the inferior wall. And then in terms of her labs, her CBC is generally stable, pretty within normal range. Her ALT and AST are within 1.5 times the upper limit of normal. And we are able to calculate her FIB4, which comes out as 2.72, which is indicative of more testing needed, and it correlates with a stage 3 to 4 fibrosis just on lab work. Her ALP and GGT are also elevated. Bilirubin, kidney function are normal. With regard to her lipids, she has an elevated total cholesterol, elevated triglycerides and LDL, and I would consider this to be a low HDL. Her hemoglobin A1C in hospital was 7.5%, fasting blood sugar 7.2, and they did screen her for viral hepatitis. So hepatitis B surface antigen is negative, and HCV antibody is negative. So in talking to this patient, she says this was all a complete shock to her. She went to the ER because she thought she was having acid reflux. She also discloses she has barely been keeping it together. She has not prioritized her own health. With regard to her social status, she is married. She has 2 teenage boys, one with special needs. She works as a police dispatcher in the office. So she basically spends her day sitting at a desk at a computer on the phone, and her work responsibilities include 2 night shifts a week. When you ask her about her habits, she does not smoke, currently does not use alcohol or cannabis, but she was drinking about 4 to 5 glasses of wine a week until 2 years ago, when she started developing perimenopausal symptoms and was told that drinking wine or stopping wine intake may help these symptoms. She readily admits she does not exercise. On exam, she looks well. There's no stigmatic chronic liver disease. Her blood pressure is well controlled. Her waist circumference is 40 inches, and her body mass index was 31, in keeping with obesity. Her heart sounds were normal. Abdomen was soft and non-tender. No flank dullness, no pedal edema. no evidence on exam of decompensated liver disease. So a bit more history. She has not been feeling herself. She's gained 15 pounds in the last 2 years. She's not sleeping because of her hot flashes. Her sleep is not restful. She goes to bed about 11:30 at night, wakes up at 6 a.m. and not certain if she snores. In general, she's too tired to exercise. She was going to join a friend at the gym, but developed her gout, which is recurrent. And she endorses a lot of stress in her life, and she's caring for a special needs son. Unfortunately, she has no other specific digestive complaints. When I ask her about her dietary history, her typical breakfast is a bagel, and if you know what Tim Hortons is, it's a very common Canadian coffee shop. She has a medium double-double, and she always thought that was 2 spoons of sugar, but it's not. It's 22 grams. She has it every day. And at lunch, she has a bagel and a glass of juice just to get her vitamin C. And her dinner will often be a salad with whatever greens are on sale, so often romaine lettuce, either with pasta or rice. And she tries to get red meat daily because she was told to get her protein. Plus, her parents were farmers, so she's used to having red meat regularly. And she does enjoy dessert most nights. And she spends the night watching Netflix, scrolls on her phone to relax. And then, as I mentioned before, she goes to bed around 11:30 at night. So this is a very typical case, and clearly there's a lot to unpack here. So I'm not going to reiterate a lot of the MASL stuff because that has been brought up quite a bit, but she clearly meets criteria for MASL. In fact, based on her FIB4, she has MASH. She may have advanced fibrosis. So as a GI specialist or liver specialist, we will be confirming this, and I will be ordering a FibroScan. From her lab work, it was a mixed hepatic cholestatic profile. So I would want to rule out concomitant chronic liver disease of other etiology. And given her age and gender, I would want to rule out specifically PBC, primary biliary cirrhosis, which is an example of autoimmune cholangiopathy. So that will be lab work that we would send her off for, as well as a FibroScan to further evaluate her. But just based on her having advanced MASH, we know that she needs to make some significant lifestyle changes. She needs to lose weight. And we've already heard from all the excellent speakers that if she can ideally achieve 5 to 10% weight loss, she may not only resolve her MASH, she may have fibrosis reversal. So we've already heard excellent talks on lifestyle modification. We've heard what pharmacotherapy we have. And if we were in the US, we would have resmetirom plus or minus semaglutide. Here in Canada, we do not have that. But as we just heard from Dr. Kim, be pioglitazone plus or minus semaglutide. And then based on her cirrhosis or possible cirrhosis that would need to be confirmed, she would be a candidate for hepatoma screening with ultrasounds every 6 months. If her FibroScan revealed a fibrosis score of over 20 kilopascals, then we could consider an upper endoscopy to screen for esophageal varices. And as with anyone with chronic liver disease, we recommend immunization against hepatitis A and hepatitis B. And that's from the liver perspective, but we still have the whole patient. So it's important to address her comorbidities and provide her with support mechanisms in a multidisciplinary setup to optimize this patient's success. So she mentioned poor sleep quality. So that would be a signal for a sleep apnea screen. Education about sleep hygiene, maybe doing something more meditative and more restful rather than scrolling on her iPhone. That might help her get to bed a little bit earlier. And also making sure she has a dark room, which can optimize sleep. She's mentioned to me symptoms of menopause a few times, and we know that postmenopausal women have more than double the risk of having MASH as compared to premenopausal women. And if she's suffering from vasomotor symptoms, this is also something very important that her primary care physician can help address, or a menopause expert could address, because we now know that there is a lot more safety and necessity to consider menopause replacement therapy for ideal candidates. And like all of our patients, a good conversation and consultation with the dietitian, which we'll hear from Shira in a moment. And physical activity, we know that what the recommendations are, a combination of cardiovascular movement, strength training. If she likes walking, any of my patients who enjoy walking, but not the gym, I recommend a weighted vest, because that will certainly optimize some of their cardiovascular performance and optimization. And clearly, we have to arrange collaboration to optimize her outcome. And I'm thrilled with the panel we have here today, because we'll hear from multiple colleagues, and especially also endocrinology and cardiology. So this is just a diagram to show that our patient is in the middle of all of these things. And while there needs to be some education for behavioral modification, we also need to deal with the more objective things, including her cardiac optimization and her diabetes management. So with that, I will turn to our panel and let me see who is going to comment on this lovely case.
Yeah, so
I wonder if it would be helpful just to go around and do a quick introduction of who the panel is. Shira, we've already heard from you. Stephanie, can you maybe just do a quick shout out and self-intro?
I'm Stephanie Gysel. I'm a community pharmacist in Calgary.
Hey, neighbor. And we know James Kim and Paolo Raggi.
Hello, I'm a cardiologist at the University of Alberta in Edmonton. I'm a non-interventional cardiologist.
Great, up just north of us. And Isabella. Sorry, make that Mia.
Hi, everyone. Mia Biondi, and I'll just ask the moderators to help me share my video because I think it's muted right now. I'm a primary care nurse practitioner and an assistant professor at York University and teach in the primary healthcare nurse practitioner program. And my research is focused mostly on viral hepatitis, but also just broadly liver disease and HIV prevention.
Great. And Scott?
Hi, I'm Scott Isaacs. I'm an endocrinologist in Atlanta, Georgia, and I'm an associate professor at Emory University and also the president-elect of ACE, American Association of Clinical Endocrinology.
That's great. Thanks.
You work with Roberto, Scott?
Yes, go ahead.
Pacifici?
Huh?
Yes, he's our chair.
I was at Emory before I came into this godforsaken place full of ice and red deer and reindeers.
Great, great. I wonder if just to give us some direction, Mia, I wonder if I could call on you just from the primary care NP perspective. Just give us the big picture when you see this this patient joy. What are your thoughts? What are your priorities?
Yeah, thanks so much for having me. And James, I just do want to congratulate you on the guidelines. I think it's just massively important for us in primary care and really looking forward to the full guidelines coming out. A few different things sort of came to mind when I was listening to the case and reviewing the case. And so maybe I'll start us off with actually not medicine whatsoever, but more approach. So a few things that came to mind is thinking about, trauma and violence-informed care and asking permission. So asking permission about that person's priorities today. What things do they want to talk about? Maybe they don't want to talk about cardiology or endocrinology or diabetes or referrals or exercise or nutrition, right? So maybe their priority today is menopause, as it is for many, many women, because menopausal symptoms are just terrible. And we know that liver disease is silent. So I think that's where I would start. I would start with, what are your priorities today? And we should all note that this case, and there's going to be lots of slides and lots of medications that we talk about, are going to take multiple visits for us to A, gain trust, and B, honestly, make a little bit of headway. So I think, Supriya, your overview of the things that we all know we need to counsel on is very appropriate, but it's going to take, possibly a year to talk through some of these things with that person sitting in front of us. We didn't chat too much about mental health in the background of all of this. And so I think that's another big flag for me, really diving into some of those personal things that are going on at home, obviously a very stressful environment, and how can we support that person from those views, because we know that mental health drives so much of this in terms of outcome. Maybe I'll stop there, but happy to jump back in later.
Yeah, Mia, I just want to highlight a couple of the things that you said and mental health. I think what we know about chronic disease management and where it falls down is often around mental health challenges. And this is a woman that's just been slammed with 101 different stressors, not having a lot of resiliency that we see. So I think that's a great point. Starting where the patient is, that other message that I heard you say, I think is really a good one. I understand that it is very late in the middle, almost the middle of the night. And so, Shira, maybe I want to invite you to give some words from a dietitian perspective before we let you go. Is it true that it's 2 a.m. Where you're at?
2.5, but who's counting?
Yeah, so there's obviously you've heard about Tim Hortons and the nutritional impact of that in Canada, but where would you start with a patient like this?
I really liked what was said about asking permission. So first of all, we need to ask permission to discuss about diet, and then when the permission is given, I think the first thing we need to do is to provide knowledge and to emphasize to the patient that changing the lifestyle is really effective in treating this disease. It's not effective in all types of chronic diseases, but in the case of MASLD, and definitely for type 2 diabetes, lifestyle is a game changer, and we need to convince them because it creates motivation. And then we need to get a long diet history to understand what exactly she eats, when she eats. Does she eat when she's hungry or when she's nervous or tired? We need to really learn a lot about her and then tailor the treatment. And we talk about weight loss a lot, 5-10% weight reduction. This is very difficult to achieve. We need to remember that that's our wishful thinking, but it's very difficult to achieve. Less than 30% of the patients actually achieve that weight reduction and keep it in the long term, even less than 30%. So we don't need to put all the focus on weight reduction. We need to change dietary habits and try to increase gradually physical activity. So she can reduce the red meat consumption, not on a daily basis, but twice a week, not processed meat. She can reduce the orange juice she's having, because we need to explain to her that although it's fruit, there's a lot of fruits in this cup of orange juice and a lot of fructose, which is not healthy for her. So we can start from very small changes and ask her if these changes are something she can keep up with, if she agrees to these changes, and then start from there. And again, to emphasize that it's not all about weight reduction. Otherwise, if it doesn't work, they feel very disappointed. They feel disappointed from themselves, and they feel that they disappoint us. So we need to explain it very clearly. Thank you.
Yeah, so really just to combine some themes there, this is not a sprint, it's a marathon that, we can peel a layer off at a time. And as Mia said, take a very patient focus with that. Shira, we're happy if you want to stay here and have breakfast with us, double coffee at Tim Hortons. But listen, if you need to get some sleep, we'll understand you're logging off. So thanks so much for your contributions.
Thank you so much. Bye-bye.
Yeah.
Thank you so much.
Yeah.
Bye-bye.
I can just add one thing. One thing I do advise our patients is that this didn't happen overnight. This was a slow process that took decades to culminate in this. So patience and a slow, methodical approach that will gain them success is really critical. And I think, as Mia said, like addressing one topic at a time, so we don't want to overwhelm her and make things more challenging that she just says, forget all this. I'm going to continue on with what I'm doing and just say, I can't deal with this. It's the last thing we want to do to her.
Yeah, so again, go ahead. Yeah, go, Paolo. Yeah.
Just a brief comment. Just 2 days ago, there was a publication, I believe in the British Medical Journal. I have to confirm that. No, the American Journal of Clinical Nutrition, where they demonstrated using the UK data bank that a high intake of flavonoid-rich fluids, which include, not fluids, excuse me, foods, which include citrus, actually improves MASLD, improves steatosis and fibrosis. So, are we really recommending against oranges in this lady? I understand orange juice, but maybe not oranges. Maybe we should be careful in what we tell these patients, because some of the things we say may be contradictory, actually, with the literature. Just a
We know
small.
we know she's vitamin C sensitive, so there's a hook there.
Mhm.
Before I bring in Scott and just ask a little bit about the diabetes control part of this, Stephanie, chronic disease is a team sport, and more one of the most important players in our team are pharmacists. How could pharmacists support the management of patients with MASLD?
Well, first, I just want to say thanks to everyone for letting me participate in our chat tonight. I know that we have attendees from kind of all over the world, the US, Europe, and South America. The scope of practice for pharmacists in all of those areas is going to be very, very different, even within the provinces within Canada. So pharmacists are very accessible. In the US and Canada, we are the most accessible healthcare provider, so we can be a huge resource for patients. This patient is very similar to ones that I often see in my practice, and I find as healthcare professionals, we often have our list of what we want to do with somebody, but I guarantee you, if you ask her, she is beyond overwhelmed with all of these diagnoses and is terrified and suddenly has a cardiologist and a hepatologist and an endocrinologist and a GP and has no idea what's going on. So I find the pharmacist can often offer a level of support and care and help make sense of all of this for patients. Depending on where you practice, pharmacists can help, even with a lab work, identifying patients who have MASLD, in administering immunizations, making sure that people remain adherent to therapies and help navigate challenges that come up with adverse effects. So there's so many areas where pharmacists can be a valuable resource and really collaborate with the patient's entire team.
Yeah, thanks, Stephanie. I'd reinforce that and also add the comment that pharmacists are the most accessible healthcare team member to most patients, and they have the most face time with patients than most healthcare professionals. So, not maximizing the strength and that you guys provide is a miss if we do it. So great to have you on the panel. So, Scott, it's about the frickin' sugar, eh? Like, what do you think about, we're teasing her with a little bit of metformin. I mean, how are we going to get those sugars down?
Well, this is a very complex case, and it's also very severe. And this patient has a very high FIB-4 score. I think a lot higher than a lot of the patients that we see. So I think it's also important to think about even patients with lower FIB-4 scores with MASLD are still at very high risk for cardiovascular complications. And so treating MASLD is about treating diabetes and managing blood sugar, but really the blood sugar is really just one part of diabetes and cardiometabolic management. And what we're looking at is where we look at MASLD as being the hepatic complication of the metabolic syndrome. And sometimes I've even referred to it, and others have, as a diabetic hepatopathy. Now, I know the hepatologists don't like it when we call it that, but I think the point is that this really is part of the metabolic syndrome, and we really want to think about this as treating the total patient. And so, when our patients have a very high FIB-4 score, their likelihood of dying is going to be from liver disease. But if they're at a lower score, if they're F1, or below, really their highest risk is going to be cardiovascular. And so, diabetes management, weight management, blood pressure management, lipids. Dr. Joshi did a really good job talking about a lot of that, but we really want to look at it as a total package. But I think that we try to look at evidence-based medicine, and we do look at the data. And, I think the medications that have been mentioned, the GLP-1s and the dual agonist, tirzepatide, that really have the data to show that you're going to get reduction in not just hepatic steatosis, but also the inflammation, the MASH. And now we are starting to see some data very early now with fibrosis reversal or preventing progression of fibrosis. And so I think that's very important to think about too. But when we talk about diabetes management, we can use GLP-1s, they're preferred. In the ACE guidelines, we look at diabetes, we have the complication-centric approach. So instead of the glucose-centric approach, we look at it as a complication-centric approach. So the GLP-1 medications, they help reduce cardiovascular disease, they help reduce chronic kidney disease, and then also with MASLD and MASH, and then obviously with weight loss. So there's just so many benefits of that class of drugs. The SGLT2 inhibitors are also beneficial for NASH, especially in reducing hepatic steatosis. We don't have a lot of biopsy data, so we don't really know a lot about MASH and about fibrosis, but certainly they have the cardiovascular and the kidney benefits as well. So if you're, again, talking about treating the patient holistically from a cardiometabolic perspective, the SGLT2 inhibitors are preferred as well. And then, we've heard about pioglitazone mentioned, and I think there's good data for pioglitazone, and I know a lot of people are concerned about it for different reasons, but I think that we're going to see in the future some new thiazolidine type drugs, pan-PPAR receptor agonists, and others that may be looking promising as well. So, I think we started with lifestyle, and I think Shira and all of us, we have to recognize that lifestyle is the cornerstone of management. But with many people, even with their hardest efforts, they're trying as hard as they can at lifestyle, and they're still not successful sometimes, a lot of times, or they're able to lose some weight, but then they regain. And that's where medications can be really helpful, because we know obesity is a disease, it's biological, and medications treat biology. And so we do medications in the background of lifestyle always, but I think all of it can be helpful.
Yeah, so great comments. It's interesting to see the TZDs. You're intimating that they may be like the phoenix rising from the ashes, and thanks for the mention of GIP, GLPs, Mounjaro, tirzepatide, and utility in that. Paolo Raggi, so let's get back to the heart. Did your heart flutter a little bit when you saw that she didn't tolerate statins after a week in hospital, and would we want to use statins on her anyway because she's got a bad liver? Your thoughts from a cardiology standpoint?
Well, there are many comments as a cardiologist on this case. First of all, many of you have already mentioned the high risk of cardiovascular complication in this patient. I wasn't given much from the point of view of what has been done in this patient yet or so far. There wasn't any mention of any planned angiography, for example. Interesting that she was diagnosed with a non-STEMI, and yet she was released from the hospital just with an echo. We wouldn't in our institution. I think that we would do a little bit more. But be as it may, as it has been stressed by many of you, she has so many problems and so many things going on at this time that we need to take it a little bit with a grain of salt and gingerly, or she will adhere to none of the recommendations. So for the moment, if I were to wear my non-invasive cardiology hat, I would put on a side burner angiography or interventional cardiology. I would manage the acute cardiometabolic problems. And I agree wholeheartedly with using GLP-1 receptor agonists upfront in this patient. I don't know if you have heard, but Health Canada approved Wegovy, semaglutide 2.4 milligram a week, to prevent risk of non-fatal myocardial infarction this week. So to reduce the risk of non-fatal myocardial infarction. This is not a prevention. In their case, it would be a secondary prevention, but nonetheless, great utilization of a drug that now has an indication. Also, she has an LV dysfunction, so she has another indication for one of these agents, with or without SGLT2. The problem with statins is serious because let's not forget that LDL cholesterol and triglycerides also very severe in this type of patient. Maybe in the absence of tolerance for statins, I may consider using IPE, in other words, omega-3 fatty acids. Since
Icosapent.
Icosapent, thank you very much.
Mm-hmm.
And that's a mouthful. Definitely in their case, the triglycerides are at least double of what they should be to be on the safe side. So yes, I would probably start icosapent ethyl. Could consider eventually PCSK9, but that adds to the complication, to the injection, to the cost of all this treatment. I'm very concerned, I'm very sensitive about the multi-therapy that we throw at our patients. It's so complex. There's so many drugs. Some is injectable in the morning, some should not be taken with food, some with food, some 3 times a day, some 1 time a day. It's a mess, to be very honest. So the lighter we make it, the better the compliance, I believe. And so maybe gentle introduction of 1 step at a time. Let's remember, I think that Stephanie said it, this happened over multiple decades. It didn't happen yesterday. So we don't have to intervene. It would be best to intervene by tomorrow morning and reduce all the risk overnight, but it's not going to happen. And I think that in order to be effective, we need to be very gentle in this patient's approach.
Good words. Before we turn things back to Dr. Joshi, the architect of this scenario, James Kim, put your family medicine and your guidelines guru hat on at the same time, and what are your sort of reflections on the case and also the wisdom that you've heard?
Yes. I mean, in family medicine, we have so many guidelines. I'm sure if I look hard enough, there will be like a left thumb pain guideline or how to avoid Monday guideline as well. And I'm sure there's evidence-based too. Anyways, so when I look at patients like this, I would look at into probably like a metabolic and non-metabolic. So non-metabolic would be probably more important, I think, in this patient would be mental health and sleep. But I'll come back to sleep. But when it comes to metabolic, and when I look at someone with MASLD and MASH, then I would look at some of the medication that comes to my mind, like automatically. Metformin is the first thing. So there are some data with the people with a MASLD where they take metformin, it actually reduces the rate of a hepatocellular carcinoma as well. So it seems to have a very nice anti-HCC impact. So that's something that I would be very interested in making sure that the patient is on. Pioglitazone, I would watch a person very carefully, given that the ejection fraction was 45%. But we do know that the weight gain, likely a fluid gain, is about 1 to 2% of the body weight. So I'll just watch that. However, there's some data suggesting that the pioglitazone, especially in people with type 2 diabetes, actually improves the heart function, especially the diastolic function. So maybe it might actually improve overall. So I don't know. The other medication, SGLT2, she's already on it. ACE and ARBs, some data suggesting that can maybe reduce some of the fibrosis as well. And statin, the very first question I would ask this patient is that if the statin was intolerant given at the hospital, what was given? So most likely it would have been like atorvastatin 80 or Crestor 40. So then how about if we reintroduce them slowly and see what happens? And then GLP-1, as Dr. Isaacs talked about, so that's great. Now, mental health is very important, but I just want to talk about the sleep. So we're actually in a process of submitting a paper for the cardiovascular impact of insomnia on patients. It's absolutely fascinating. So we do know that just because you don't sleep, which we consider as a pillars of life, one of the pillars of life, or some people actually now call it a foundation of life because it impacts everything. We know the shift worker, there's a data from Korea that shows the shift worker, there's an increased risk of MASLD, just right there. Doesn't have to have an OSA, but the person just with an insomnia alone, there's a huge increased risk of the MASLD and the worsening of the MASLD. So things like a CBTI now. So Dr. Joshi, as a hepatologist, that talked about the CBTI, which is amazing. But there are lots that we can do in primary care with the sleep. There's some very good medications, very safe medications that are very effective now as well. So those are some of the things we can talk about. OSA is very important. Over 50% of the people living with type 2 diabetes have OSA, and worsen the OSA, we know that there's a worsening of the A1C and fasting glucose as well. So I would probably list a whole bunch of things that I think we should discuss with a patient, and just like the way that Mia has approached very beautifully. Like these are the things that I want to talk about today, maybe, and what are some of the things that bothers you most, and maybe combine some of my main interest and some of her main interest, and talk about that and go from there. Yeah.
Yeah, I love that. And your comment about the overlapping themes, not only in how to approach the patient, but also overlapping themes in terms of therapies that may help one thing will help something else. And sleep is a really good place to end on. Although I feel a little bit guilty about disturbing our Israeli colleagues' sleep tonight. I'm glad she wasn't on line to hear that factoid. Dr. Joshi, take us home on this case, and I'm going to invite people that are on the audience, again, throw in your comments or thoughts, but Supriya, I'd just be interested in your reflections on what you've heard from the panel.
Well, I think this has been super insightful because this was a fabricated case, but I was just on call last weekend and I saw this case and a smattering of individuals I had to go see on the weekend. And yes, to address everyone's concerns and comments, is a complex patient, but this also ends up being the everyday complex patient that's at risk of poor cardiovascular outcomes, that's risk of decompensated liver disease. And if they have that cardiac disease, are they going to be a candidate for liver transplantation? And one thing about this patient scenario is that we are so lucky that this isn't a year where we finally have pharmacotherapy to offer patients like this. Yes, there is the concern that she may have cirrhosis, and more investigations will help sort that out. But my comments mirror what I've heard here, that she'd be an excellent candidate for GLP-1. She would be an excellent candidate for having some one-on-one time with a dietitian. She may feel greatly improved with just a good night's sleep. And I think once you address, what are her priorities, as Mia beautifully set out, I think that's very important. What is bothering her the most? And that will then direct what her motivations are, and that will give her the success, because we all know when you're tired, you don't want to go to the gym. You don't want to go for a walk. You don't want to cook a nutritious meal. That's when you're tired, is when you want to lie on the couch, order takeout, and not do anything. So I think addressing the things that are affecting her the most is important. So her sleep quality, I think when that improves, her nutritional quality will hopefully improve, and that will gain her the motivation to want to start regular movement. And one thing I do talk to my patients about, and is that with experience of being in practice over 20 years, saying just go lose weight, see you in 6 months, that approach does not work. And I find that by pointing the issues out where someone can make a change, and then if they enjoy that change and continue with the change, the weight loss is a side effect, which happens. And that's the beautiful part if lifestyle change can be maintained. And while we know that's a struggle to maintain it, we then have pharmacotherapies to support patients like this to improve all their outcomes that we want to prevent them from having. That's my take home on this patient. And in the ideal world, I would absolutely, this is like my dream day, to have a panel full of all of you on board to manage all of our patients every day. That's the ideal situation. Whereas in reality, I know I'm on my own in my office. I don't know how you guys are, but I think most practitioners in the world are on their own. And I think this is a dream situation of having a multidisciplinary team right at your fingertip. But that is the ideal world to optimize patients like Joy.
Really good. Mia, come on back. If you got some comments to share.
Thanks. Really good discussion, and Supriya echoing that. It's so nice to hear from everyone. I just, I didn't prepare anything for this, and I think that's the most fun about these types of panels, because things just come to you, right? So I love that we're talking about evidence-based medicine, and I want us to think about evidence-informed practice, which also includes patients' culture, history, and the local context, because we haven't even talked about reimbursement and who's paying for these medications and how that's going to impact our options, right? But it impacts our options a lot. A couple of things that came to mind around sort of that idea of not making assumptions is maybe injectable cholesterol medication is actually exactly what this person wants. Maybe that approach could be a first line approach. James, I think probably you and I see this all the time. People get on a statin at a low dose, and they're at a low dose forever because someone has trialed them to tolerate this statin and they never increased it, and it's doing absolutely nothing. So I would just say, maybe it's not statin, maybe it's another approach from the get-go if the person wants it. And then, I don't know, I'm really sort of particular about this, but this idea of discussing weight loss, I actually kind of think we need to remove this type of discussion, right? Like, we know clinically this is what the guidance tells us, but we probably have to totally remove this language. It's like in this particular patient, it's going to be extremely difficult. So let's just take it out of the discussion, right? Let's talk about cardiovascular health. Let's talk about increasing insulin sensitivity, but let's just take the weight loss conversation off, because it's very difficult, even if this person could do 150 minutes of high impact aerobic activity, which we know that's hard for all of us. Sorry, that's my 2 cents.
Thanks. No, Mia, that's great. And speaking personally, yeah, let's take weight off the off the dialogue. But in saying that, and we've got about 5 minutes left, and just so that you can put your thinking caps on, I'm going to go around and ask all of you for one key message that you want the primarily primary care audience to have that's listening. Supriya, I'm going to bring you in on this question. Good question in chat, and timely with Mia's comment. But is weight loss mandatory to see improvement in MASLD?
Well, I look at weight loss as a number on the scale, and what you want to have happen is changes in the distribution of fat and in building of muscle. So the number may not change for some people. But what happens is that waist circumference shrinks down. That's that visceral adiposity that is the basis for their cardiometabolic risk factors. So I would say shifting the body composition is really what I want to have happen for this patient with your mechanism of things. And with that, they will improve as we've just said, this is all about improving their metabolic health, improving their insulin sensitivity. And that will happen when they make those changes. And weight loss, as I give my patients, is a potential side effect, but not my ultimate goal. But if you make these changes and do all of this, that might happen.
Good stuff. And it brings in that whole concept about adiposity rather than weight and how we use that. Okay, one quick key message for our audience. We've got 4 minutes and we've got lots of good minds here. Scott, why don't you start us off? One key message that our audience should take home from tonight.
Well, the primary care doctors that are on this call, I'm really preaching to the choir because you're the ones that have the awareness. But what I'd say is we need more awareness, because 38% of the population has this, almost 70% of patients with diabetes. So having that awareness and then screening the high-risk patients, diabetes, obesity, dyslipidemia, and not screening, like Dr. Kim said, not screening for fat, but screening for fibrosis, so we can prevent that progression to fibrosis, cirrhosis, liver cancer, and liver-related deaths.
Good words. Paolo. And just remember the mute, Paolo.
Pardon. I was talking to myself as usual.
The mute button is a new feature with this telecast, so I know.
It is new. I would encourage our primary care physician colleagues to refer more patients with advanced MASL to cardiology. I think that I'm one of 3 cardiologists in North America that has an interest in the subject. And I'm not trying to be exclusive. I'm trying to say that we need more awareness in my own field, that this is a true problem for cardiology. So yes, when you encounter a patient, maybe not in the early phases of MASLD, but when you have patients that are galloping toward MASH, you may want to start considering a referral to cardiology for proper evaluation of cardiovascular complications, which, by the way, are not limited to coronary artery disease, but valvular heart disease, atrial fibrillation, congestive heart failure, you name it, they keep going. So an important message to my own people from your people.
I love that. I love that cross-pollination that you're encouraging, because I think the more that we break down silos and increase those connections, the better patient care. So thanks for that point. Stephanie, piece of wisdom for the gang.
Find a pharmacist you like and use them. We are a huge tool for simplification of medications, like even looking at this patient, simplifying her metformin and EMPA to Synjardy. Like, let's reduce that pill burden, get a medication schedule going so it's nice and easy, and have a resource to investigate coverage for the more complex therapies like PCSK9s and GLP-1s. Don't assume somebody won't take it, because sometimes they are covered and sometimes patients just want to pay for them.
Yeah, a lot of good points in there. Stuart Ross's wisdom is don't assume that a patient won't want to pay for a superior medication. Also, your comment about trust, and I think nothing builds trust amongst healthcare providers better than working together on behalf of a patient, and the pharmacists that I work with certainly take that approach. So Mia, the point you'd like to make to leave us tonight.
Sure. So I think this is a case that's, we would all know something is wrong in primary care. This is not the typical case that we would see most of the time. And so this person had a wake-up call, related to a hospital discharge. But patients do have these wake-up calls pretty often along their journey with us in primary care. So I think, co-localize the care would be my message. They're coming in for something else. Let's do something a little bit earlier than hopefully they don't have a FIB-4 of 1.3, and we can manage that and we can keep it there. If I can make a second point, we all have a role for educating the next generation of learners. So please pass along what you learned here tonight, because although it will come out soon, I would not say it's common knowledge whatsoever to screen in diabetes. And so let's make sure that our learners and next generation also know this information.
Right on. Share the wisdom. James, 15 seconds. Give us your pearl.
So having a fat in the liver, I thought it was normal, because I thought there was a function of the liver. So what? So what's the big deal? Well, there is a big deal. At least 40% of those people that we see with type 2 diabetes actually have a pretty bad liver, and at least 15% of them are not doing great. Let's find these people, and then let's prevent the complications. The treatment for diabetes, we're moving away from glucocentric approach to target end organ damage control. So let's change the mind shift, and then there's so much that we can do in primary care, and we can prevent a lot of complications.
Great stuff, James. It's great stuff. It's more than just the blood sugar. Dr. Joshi, give us the final word on this section before we turn things over to Michael.
Thank you. Well, James kind of stole mine. That is liver fat. Fat in the liver is not supposed to be there. It's been so normalized because it's so, unfortunately, so common in the population. But fat is not supposed to be in the liver. If it's there, question why and what is going on, and begin investigations. And if they're pre-diabetic and have type 2 diabetes, screen. I love those 3 S's that we heard earlier today. Yeah. Screen, stage, and start treatment.
Yeah, love it too. A simple message that just resonates and really picks up what we've been talking about tonight. Thank you so much to the team and the panel, and great case, Dr. Joshi, and thanks for your participation, audience.